And this is kind of sort of common iceberg metaphor, which is here. You think about this iceberg, and psychiatrists and psychologists will know that tiny tip of the iceberg of the kids that actually make it in to get services. The bulk of the people, I would say 60 to 70% of the kids, will be aware of illness, but have not sought advice, will have an emerging illness, but not really fully aware that they have an ongoing problem. And then there's that chunk that are well, that don't really have an illness. And the thing with public health is, we're trying to treat that whole iceberg. And it separates out medicine and a lot of clinical researchers who are just looking at that tip, who've already recognized they've got an issue and have made it in to see a service provider. So I'm going to go kind of quick through some of these first few slides. But looking at e-mental health, I think you really, if you're going to look at this public health perspective and try and catch mental health early, you need to look at youth. So the onset of most mental illness occurs in adolescence and young adulthood. Young people aged 15 to 24 are more likely to report mental illness or substance use than any other group. We heard to report 1 in 5 people experience some sort of mental illness in a year, so it's 20% of youth. And it differentiates out, so you have 14% of youth aged 12 to 17 and 27% of youth aged 18 to 24 experience a mental health problem in any given year. I won't go on, but I think it's safe to say that mental health in youth is a big issue. If you're going to go for prevention, so you need to tackle the youth, and especially I'd say down to 12 years old, 15 years old. So to present these series of points in sort of a graphic diagram, this comes out of, and Kathleen will work is probably familiar with it, comes out of the Victorian Burden of Disease study in Australia, and it's 1999. But those of you that know DALYs, disability adjusted life years, so it's the amount of disability associated with an illness. So it's not death, but a 0.2 of a year. So if you have a 20% reduction in your sort of quality of life, you could think about it for your abilities. So you can see the key, I'm not sure which is the pointer, this one? Yeah. Each one of these colors represents a different disease. Age is here. So you can see mental health here. So the key burden of disease, this is incidence of years of life living in disability per 1,000 population. Because you don't die, you might have a 0.8, so a 20% reduction in your ability. So look at mental health. The biggest burden of disease is between, say, 10 and 30. So this is where the biggest impact. And not only is that the biggest impact in terms of mental health and over the course of your illness, it's probably the biggest impact of any other conditions by a long shot in youth. So in terms of looking at mental illness, you really need to look at youth, and you need to look here early on. I'm just putting these up there to hit at home that if you're doing mental health prevention and mental illness, hitting it at youth, and if you look at other diseases, it's sort of a no-brainer. There's no question that we shouldn't be putting a lot of resources into early identification and prevention to youth. There's no question about it. The other thing I put up here is that adolescence is a period of, in my research, I'm more on substance use, but emerging mental illness as well, a sort of complex emerging vulnerabilities on numerous fronts. So adolescence, I've stepped out of 3 kids. This is one of my kids, the youngest and kind of wildest. She's 21 now. So this is 12. This is probably 13. This is provincial gymnastics team with Phoenix Gymnastics, UBC tennis lessons, all that stuff. 13, 14 shifts to grade 8 high school boys kick in. 15 to 18, okay. I'm a stepdad, and my kids are from the Yukon, a small village up there, 3 of them. I've been raising them 18 years, and a lot of problems. A lot of early childhood problems, really severe, and genetic family issues as well. This one's given me full permission, and I've shown these slides before. This is probably the last presentation of these slides, but this is what happens. Nice kids doing math homework. A year later, grade 8, and boys, 15 less. The family hasn't changed, right? This is the kid. Lots of piercings. She's got drop acid tattooed on her knuckles, drinking beer, marijuana leaves. When I say kids sharing information, I'm on her Facebook. I don't comment a lot, but she's totally okay with it. It's kind of scary. And her friends, same thing. Their perceptions of privacy, very different. Totally okay with me knowing she's fluid, pansexual now, like she's in her 20s. very different from when I was a kid. So that notion of where kids see privacy in terms of their sexuality, their substance use, is very different. So I think we can use that to our advantage. But the point I want to make here, huge vulnerability in terms of access to substances, but also emerging mental health starts to take off with puberty and risk-taking and all sorts of stuff. Sometimes it's hard to differentiate their depressive, their mood swings with emerging mental illness. You can't really see it here, but she's got lots of cuff marks here. She was off, quit school, into a total ed program, living, I wouldn't see her for 2 weeks. She'd be on the streets, panhandling, everything. But then they come out of it with the right support. And you can get to 19, 20 here. She finished school in an alternative program, did some other things. I was so happy I sent her down to Costa Rica for 3 or 4 months. This is a happy story with someone like me with a flexible job, with the right supports, a lot of counseling, an alternative school with really small classes, almost like a second family, right? This doesn't happen with a lot of the most vulnerable kids in our society. This is really vulnerable time. She has generalized anxiety disorder, gets counseling every couple of months from a psychiatrist, and is on some, I think, antidepressants, but low dose. She definitely has some issues, but what prevented them from becoming severe was good intervention here. And I put these pictures up here just really, I work with a lot of the people here just to really take the lead, and not the lead, but if I want my kid to break down the stigma and talk about it, I think I have to step up and start talking about my family and start breaking down stigma that way too. So part of this, while she was still in elementary school, before using any drugs or anything, I thought kids are all, the right support going to be great. I developed what was called the British Columbia Adolescent Substance Use Survey. So this is a hybrid model. The web was just taking off among youth. I said, instead of doing paper surveys around the province, let's do a web survey. And hey, the schools are all busy. They don't want to have to administer the surveys throughout class time or anything like that. They said, oh, we don't have time. You're going to have to pay people to come in to administer. I said, well, let's do it on the internet. Some schools can have kids do it in school. Some kids can just do it on their own time, right? It also allows for complex skip patterns, like depending on your ethnicity, you get certain questions. If you've never smoked, you don't get any questions about how often you smoke. It gives you the ability to do random assignments. So within this big cohort web-based study, we randomly assign smokers to some messages and other messages. So you can embed little randomized trials and evaluate the impact of all sorts of things, giving them videos. We just did messages at that time because we didn't have the capacity for videos. This was a $1 million project, and we followed the kids every 6 months, and then we collected 7 waves of data from about 1,800 kids, 3,000 enrolled by the end of it. We used email for reminders every 6 months. We put up posters in about 70 schools. We got their emails, so we sent email reminders. So anyone doing email reminders, look at MailChimp. You can use an email marketing platform that just makes it so easy. You can monitor whether your emails are getting caught in spam, when they get opened, what links they click. Really easy to use. We use text messaging. We use paper mail for those that wanted it, and in-school reminders. So all of these tools are an epidemiologist's dream. They're really cheap now. And if you're in epidemiology and you like giving kids surveys, getting data, and actually having your choice to include lots of information on a survey, and only having kids fill out what's relevant to them, you don't have to print off a 60-page survey because of the skip logic. Kids are just answering the questions they need to. Plus, you can embed randomized trials. So you can see how, as an epidemiologist, I got pretty excited about this technology. This was about 7 or 8 years ago. So it started in grade 8, followed them every 6 months, and we collected data for 4 years. The first year was just sort of getting organized. We just finished collecting wave 7 at the end of December. Worked really well. This is just a screenshot. You can have information for parents, information for kids, all on the home page. So that helps too. And then they clicked on the survey and got to a traditional survey, very much like you've seen with Likert-style scales. Core content, substance use, intentions to use, expectancies, periods. We got into a lot of psychological stuff. We want to look at mental health, both wellness and illness, so resilience, self-esteem, spirituality, pubertal status, so Tanner stages, childhood violence and neglect, and indirect assessment of that, stressful life events, attachment styles, coping styles, internet use. So we have compulsive internet use related to social media and also more generally. So is your internet use, how much are you using it? Is it starting to interfere with your schoolwork and your daily lives? And then we had some core content on sensation seeking, impulsivity, hopelessness, anxiety sensitivity, depression. Once kids started using substances, their motives for use. So starting to get at that self-medication piece. So why are you smoking pot? Why are you drinking? Why are you binge drinking? And then we have questions on preferences for digital media. So would you use the information for online, like websites, videos, YouTube videos, email, for mental health, physical health, and substance use information. A lot of this content we alternated every 6 months, so it wasn't all in every wave. Some of it was in every wave, but the core psychological content was every other wave, because we felt we only needed to assess that every year as opposed to every 6 months. So here's some preliminary results. This was data collected, data collection finished last December. So this is just the CSD, the 20-item depression screen. And I know I just ran these numbers just on the weekend. So there's a lot of debate on what cutoffs to use for the CSD for mild, moderate, severe, for adolescents, and across boys and girls. But I just used less than 16, less than 20, and then between 16 and 21, 21 to 31, 31 plus. So the notion, this is a web-based survey. I think this 1,200 kids did this way. Is this a problem? So look at the numbers we've got. So in boys, 361, 75%. Here, no problem, so that's not bad. That's about what we expect. But look, 9.5% mild, 9.1 moderate, 6.4 severe. So look at this. 9, 18, 24%. Girls, close to half having mild, and a little less than half going up that way. So it's definitely an issue among these kids. And this is kind of a mainstream kids. This isn't kids, these are kids who are in school and doing this survey. So if anything, this is probably an underestimate of the true amount. So the notion, just confirming it is a big issue. The screening tool seemed to work pretty well. The next thing we did in the survey is the percentage of youth reporting online resources in the past 6 months for mental health problems. And it included in the brackets, for example, dealing with stress, depression, etc. And the percentage who would use in the future 6 months. So the black numbers, that's the percent who have used it in the past 6 months for mental health. The red numbers was a hypothetical scenario. Would you use it if it was available or if you needed to? So for the kids that scored under 16 on the CSD, 41% had used websites in the previous 6 months, 10% had used online videos, 4 online discussion groups. And then we said, if you needed help, would you use? Look, 73 would use. So look at that gap between how many had used and how many would use. And I think they're just either don't know they have a problem or don't know there are good resources out there that would help them, right? So there's 2 reasons why they wouldn't use resources. They don't recognize they have a severe depression problem, or they recognize they do but don't see the internet as a resource that they would use. And there it is for online videos. See, videos are still lower. Websites is still #1, and these are kids who were about, I think, average age 16. And online discussion groups are kind of lower. Social media was low, but I think this still is the stigma issue. They're a little resistant to talk about that online. Then we asked, why aren't you using mental health services? So the Mercury Center Society, so of kids, so this is the question, in the past 12 months, did you ever feel like you needed care for a mental health issue like depression or anxiety, but you didn't use any services or get treatment? So 270 or 16% of the kids said yes, and then reasons for not accessing. So these are my numbers in the red, and then a report from Mercury Center Society, which is all high school kids, are in the black. The biggest one here is I thought the problem would go away. I didn't want my parents to know. I didn't know where to go. These are the big ones. I'm afraid someone might see me. So you can see how screening could address these things. If someone completed a screening questionnaire, you could provide tailored feedback as part of that screening questionnaire and tell them, well, it might go away, but you could give them information that if it comes back or if it doesn't go away or signs to watch for. You could indicate that, provide them information to take these kids, say, okay, this is where, if it comes back or lasts this long, this is where you need to get help. Didn't want parents to know, well, at least you could provide online resources or provide other people that they could contact, so a kids helpline or the resources on MindCheck. And again, if you're doing online screening and it's private, you don't have to worry about people knowing what you're putting on your questionnaire. It's all confidential.